At this point in the evening, we're going to turn to our panel of exciting, innovative speakers. And I would like to introduce Dr. Alex Collins, who will be moderating the panel. And thank you very much.
So our first panelist is Dr. Rachel Whiteman. Dr. Whiteman is a primary clinical physician and is in the evaluation and management of drug toxicity syndrome. And she is a emergency medicine physician here at Brown, and she will be our first speaker.
This is an initiative that's near and dear to my heart that came out of the COVID-19 pandemic. And my hope today is to talk about what we did with the goal to have lessons learned move forward and take the good things that came out of the pandemic as we hopefully move forward with it. So just very quickly, I want to acknowledge the groups that supported this effort: Rhode Island Department of Health, BHDDH, the Rhode Island COBRE on opioid and overdose, as well as Lifespan. So before I get into talking about how and why this program came about, for those of you that aren't familiar, I'm just going to talk about what the Rhode Island buprenorphine hotline is and how it functions. So it is a 24/7 telephone-based, telephone-only bridge clinic for buprenorphine. And what that means is that anybody with opioid use disorder or in withdrawal in Rhode Island can call the hotline, and they get hooked into an access center that registers them and connects them in real time, no matter time of day, middle of the night, with a buprenorphine prescriber. And they have a telehealth encounter. So it's like a clinic visit minus the clinic. So pretty much the same things that you would normally have: history, substance history, and an evaluation to see if buprenorphine would be a good medication for them and a safe medication. And if it's found to be, they then get a real-time prescription for buprenorphine. And we additionally co-prescribe naloxone. We provide additional harm reduction services and referral and linkage to ongoing treatment. And right now, and pretty much throughout running the buprenorphine hotline, we've been 6 providers, and we've gotten extra help from the Rhode Island Hospital Addiction Medicine Fellows as well. And because it's a funded project, it's free right now, at least while we have funding. And that's what it is. And now I'm going to go kind of into the background of how this initiative came about, why it's so unique, and why this was never done before. So pre-pandemic, in order to start on buprenorphine, you needed an in-person visit. So you needed to see a provider in the clinic, have a physical exam before you could get a buprenorphine prescription. And in March 2020, related to COVID-19 and increased barriers to accessing care, HHS and DEA, they released regulatory flexibility around substance use disorder and buprenorphine prescribing. And the really important parts of this is that they waived that initial requirement for an in-person visit, and they also allowed telephone-only visits. And we saw this as a huge opportunity. And I'm going to kind of go through the steps of our reasoning, why we thought this was such a good idea to try to provide to the people of Rhode Island. So this is the data that was out there for buprenorphine telehealth before the pandemic. So it had only been used for maintenance treatment, never buprenorphine initiations. And this is data from University of Maryland and West Virginia that showed the similar treatment outcomes to in-person care for telehealth delivered buprenorphine. And in the West Virginia article, they not only looked at telehealth delivered buprenorphine, but they also compared it to their in-person clinic care and had similar treatment results. And there's similar data across veterans, across obstetric populations, where telehealth buprenorphine was actually incorporated into obstetric care and had similar maternal and fetal outcomes compared to in-person care. So we knew that there was data that buprenorphine delivered via telehealth had similar treatment outcomes. Additionally, we knew the safety profile. It has ceiling effect on not only opioid effects, but also respiratory depression and CNS depression. So what kills an opioid overdose? We also knew that diverted buprenorphine most often is used to treat withdrawal or because of access problems and stigma. And we knew that the same PDMP kind of guardrails would be in place when we prescribe via telehealth versus in-person care. So we felt confident that this would be a safe way to deliver buprenorphine. And additionally, unobserved buprenorphine initiations were really taking hold and showing good data of efficacy. So ASAM, ASAP, we're all advocating unobserved initiation. So us prescribing and having people start buprenorphine wherever they were was an evidence-based approach. The other thing that I took from my own kind of personal experience as a medical toxicologist, I trained at a poison center and I took poison center call. And when you work at a poison center, you're giving telephone only, audio only consultations over the phone to patients, to parents, to providers for complex poisonings and environmental exposures. And so I knew that really high quality care could be delivered over the phone and that you could really talk with people, get to know them and be able to deliver good care. So based on kind of that knowledge block and the new regulatory changes, we set up the buprenorphine hotline. And the goals of the hotline were to provide low threshold buprenorphine access. We knew that there were barriers based on income, geographical barriers, barriers based on insurance status and race to buprenorphine access pre-pandemic. And we knew that those gaps in access of care were only going to be exacerbated with COVID-19. So we made the hotline 24/7. We had full interpreter services available over the phone for patients, and we made it free. We wanted to reduce stigma in order to maximize harm reduction approaches. And not everybody wants to be seen in their environment at any moment in time. And so the audio only option really lets people call wherever they are and kind of takes that element out of the equation. And I had people call who had never ever before accessed substance use disorder treatment because they felt comfortable picking up a phone and talking to someone where they didn't feel comfortable going into a clinic or necessarily being on video. So we really kind of were able to break through some barriers with this approach. The other thing we wanted to do and why we went telephone only was that we wanted to improve equity in addiction treatment. And we knew that there's a digital divide. So there are disparities in who has access to high broadband, who has access to smartphones, phones with good data plans. Because if you're going to use an audio-visual platform and you're doing it over your phone, you don't only need kind of the app and the resources to be able to do it. You need that good data plan and you need to have minutes and funds to do that. And with closure of public spaces, we knew that public Wi-Fi was going to be less accessible. All right. So that's what we did. And this is preliminary data that's kind of, we're hoping to put out more detailed data and hopefully get that published soon. But this is from the first 9 months we ran the hotline. And we had 131 unique callers. We prescribed 95 new buprenorphine initiations for unobserved starts. And of those prescriptions we provided, almost 94% of them were filled. So people were not only speaking with us on the phone, but they were going to the pharmacy and they were picking up their prescriptions. And we had really good follow-up. So these follow-up numbers are actually better than a lot of the clinics in the area for in-person retention and care. So we did our follow-up because we were referring all throughout Rhode Island. So we were directly connected with the Lifespan Recovery Center because we used their access center to register patients. We could directly get someone a clinic appointment there, but based on where people lived or where they wanted to seek treatment, we helped link them to resources all across the state. So we used the PDMP follow-up data on whether or not they had a repeat buprenorphine prescription within 30 days, and then also 6-month follow-up data of repeat prescribing. And I'd just like to especially thank my partners on this project, Dr. Samuels, Dr. Wunsch, and Dr. Clark. And thank you so much for having me and letting me share this experience.
So our second speaker today is Gordon Casey. After 15 years as an entrepreneur and lawyer in the financial services sector, Gordon now works on the Brave Technology Co-op, which is a platform for folks who use drugs to stay safe and alive no matter where they are. So.
Hi. It's not on? I'll wait. 1 minute. So yeah, my name is Gordon and I work at Brave. Brave is situated on the unceded and stolen territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. I'm a settler there. That's also known as Vancouver, Canada. We also have an office in a place also known as Columbus, Ohio, which is the traditional Shoandas Tula, Shawnee, Miami, and the Hopewell Nation territory. And I look forward actually this weekend to looking up some of the ancestral territories that I'm on here while I'm in Providence. I don't know much about it. Most of these figures are familiar to everybody here. About 100,000 people died last year of preventable overdose between Canada and the US. People use drugs for all sorts of reasons, and those drugs might result in overdose due to a variety of factors. But as Dr. Kim said earlier, every one of those deaths was preventable. The reason why people die from an overdose is pretty singular, though. And that's because we didn't get there in time. Most of the time, we don't even know that it happened at all. We need to do so many things. And those 2 slides of the things that keep Dr. Kim awake at night are the beginning of all the things we need to do. We need to have more safe injection sites, more safe consumption sites. We need a safe supply. We need to ensure that people are aware of what is in the substances that they're consuming. But even if we did all of those things, it is still not enough. We need to do more because people will continue to use these drugs. They will use drugs alone. And because of that, they will overdose and they will die. So the question is, for us, for Brave, and I invite everybody else to ask this question, what can we do now for the people that are using drugs today and that are going to overdose today, and that can be made accessible to them right now? Brave's framework is to try and detect overdoses. We believe that if an overdose can be detected, then it doesn't have to be fatal. And although this is what we've been doing for the last 5 years, the actual language around it is new to us, which is why I wanted to share it with folks today. I think it's a framework that allows people, all of us collectively as part of the harm reduction movement, to have a fuller spectrum of solutions from prevention through detection all the way to response. To date, we've detected 104 overdoses at Brave. And that's through, these three tools. It's an app for people who are using at home alone, a button for people in supportive housing, and a radar sensor for places such as washrooms. In addition, we partnered with a group in Ontario to launch a Canadian phone line. It's a copycat of the Never Use Alone line. And it's this t-shirt I'm wearing today. And they've also detected 39 overdoses to date. And I know that Never Use Alone has detected around about 30 as well. So collectively, these very new and pretty unfunded solutions that are out there have detected close to 200 overdoses in a really short period of time. And it's because of, I believe, it's because of this framework. So that's it. This is kind of what I have to say. For those of you who are participating in the hackathon, I'm around all weekend and I'm happy to, I'm available for anything. Brave is a cooperative, and so this is my last sort of piece for you, especially if you're thinking of considering going further with your solution or your innovation. And we're a cooperative that is owned by the people who use our technology, and the people who work on the team, and anybody who happens to invest financially. So essentially, anyone who's contributing to the success gets to own the organization. And our co-op, the team that actually works on it, is made up of this really unlikely collaboration of people. There are drug users, there are sex workers, there are engineers, there are entrepreneurs, and people with lived and living experience. And all of us, sadly, have lost friends to overdose. Almost all of us have responded and revived people from overdose as well. Literally hundreds of people collectively from our small team. And we've lost people on our team to overdose as well. So it's been, sadly, the full gamut. Thank you.
So our third speaker is Lieutenant Stephen Murray. He is a lieutenant at the Regional Ambulance Service in Western Mass, and he has served Berkshire County as a first responder since 2013 as a firefighter and paramedic. He shares his lived experience as a person who used drugs, as well as his professional experience on the front lines of the overdose crisis. He is the director of Never Use Alone, Massachusetts, New York, Vermont, and a grad student of public health at Boston University.
Hello. Whoa. All right, hold on. Hi, thanks for having me. It's really exciting to be here, meeting a bunch of people that I know through the Twitterverse. It's been a real highlight. So as Alex said, my name is Stephen Murray. My main day job, I work as a frontline paramedic in Western Massachusetts. Our agency covers 265 square miles of rural Western Mass and Southern Vermont. And I've responded to a lot of overdoses. In my career, I lost track, but it's over 100. I've been the guy that has to tell, parents and family members and kids and loved ones that their person is dead. And that I carry that weight with me everywhere. And I think that one of the reasons why I carry it so much is because I'm also an overdose survivor myself. So it was inevitable, I think, that someday I would become able to come out and talk about my recovery and find ways to move upstream in the process. Being a paramedic, like the old public health adage of like fishing people out of the river, like I am the guy who's stuck in the river all the time. And so when I became involved with Never Use Alone, it was like something that actually is going to help prevent me from having to do my job. So what is Never Use Alone? So Never Use Alone is the American counterpart to Brave. We have a really great relationship with our friends. We're a virtual supervised consumption site. We connect people who use drugs, and our operators are amazing. We've taken more than 4,500 calls. We've had 28 overdoses on the hotline. And our more than 50 volunteer operators are around the country. And it's really an exceptional group of people. And I think that a couple of things that Dr. Sue said really resonated with me, which is that, what happened at the very beginning of the hotline was that one of the hotline operators was a person who was in recovery. And when she had a recurrence of use, didn't feel comfortable calling the hotline herself and talking to her friends because she didn't want them to know that she was using again, and she died. Her name was Mandy. And because of Mandy, we have a very upfront policy, which is that people who are currently using are able to be hotline operators. We don't have an abstinence requirement. We're not a recovery hotline. And so it's pretty amazing. We ask our operators, like, if you wouldn't be able to drive a car, like, don't answer a phone call. It's really easy to hit pass and move on to the next operator. But our operators are people who have living experience. And it really is amazing to listen to these calls. So our service is free. It's available 24 hours a day. It's a 1-800 number. So one of the things I love is that, if you had a phone that didn't have minutes on it, for example, you could still call. If you're on a public payphone, you could still call. We are really good at helping to help people think about like how to make their positioning more safe, for themselves, for first responders, for pets. The worst thing is like you overdose and the police come and shoot your dog. Like that's not something that is a good outcome of an overdose. So we ask people to secure their pets, to put away any drugs that they're not using in the moment, to hide them out of sight, and to move away from doors, because I can tell you, I'm really good at breaking down doors. I break down a lot of doors. I really enjoy it, but I can't break down a door if you're sitting up against it. I have to call the fire department and they have to actually take it off the hinges because it's impossible basically to break, unless I can break it in half. We have to get the door off the hinges. So if you can ever tell people like, don't sit up against doors for using, sit across the room, it's much, much easier for us to get to you. So that's just a piece of experience that I brought to the organization that we try to implement some of my knowledge as an EMS provider. We also are able to get people connected with syringes and other harm reduction materials. And many of our callers have become operators, which is really cool. It's like this cycle because you don't have to be abstinent. You could call one day and then the next day we train you to be an operator, and it's a really great self-sustaining model. So community engagement, I pretty much present almost every week to community groups. My counterpart, Jess Blanchard, who's the director of education for the national organization. She and I both are all over the place, thanks to Zoom, making presentations to community and tribal coalitions, hospitals, addiction medicine groups, primary care providers, treatment centers, detoxes, jails, prisons. And it was really cool because the Healing Community Study, which is like this federal money, adopted us as an intervention, which I thought was really cool because supervised consumption sites aren't really legal. And they let us put up these bus ads in Brockton, Massachusetts. And this bus goes into a high overdose area. It was up for 3 months and it was pretty cool. It did increase call volume in that area. So it was something that was worthwhile. So one of the things I like to remind people, so the list on the left is the list that I think most of us are used to seeing. So actually the list on the left is what's adopted from like Massachusetts Department of Public Health, their list of risks for fatal overdose. My list on the right is unfortunately from lived experience. And the one I'm going to highlight is, and the reason I bring this up is that one of the things we have to think about is we have to get a little bit more creative with who we're reaching out to prevent overdose. And so one day, a police officer called me from our town and he said, hey, we just arrested this guy and he's going to be locked up for the whole weekend. It was a holiday weekend. And we're really concerned about his girlfriend who he was beating up because she's going to be using a loan for the weekend while he's gone. So he's removed from the situation so she becomes more safe from not being near him, but she becomes less safe because now the person that she uses with isn't there anymore. So what was our solution? We got her hooked up with Never Use Alone and she called the hotline all weekend. It worked, kept her alive. That's the type of thinking that I wanted to encourage people to think about. Like, so when we talk about, someone who is at high risk because they just came out of detox or residential treatment, when not just is that person at risk, but the person who's left behind is at risk because now the person that they've been with. So I want people to get a little bit more creative on how we think about who's at high risk. So where are we going? Our 501c3 application is in progress. We have formed a board of directors, which is this beautiful group of people over here. And I'm really excited that actually we're going to be shutting down the Vermont hotline and creating Never Use Alone New England, which I'll be the director of. And so we're really excited to be working with our peers here in Rhode Island. We're going to be trying to expand the amount of cards that we're giving out here. So if you're from like a syringe exchange or you're somewhere where you can give out cards, send me an email. As soon as I have them, I'll send them to you. We are also launching a Spanish hotline, which has been on our list to do for so long, but we had to get like a critical mass of available operators who could take calls in Spanish, which was not as easy as it sounds. And we also hope to ensure our operators reliability and be able to pay them cash stipends for taking calls to encourage taking calls in the off hours. So I think that we're an essential part of the harm reduction toolkit. And I like that Dr. Sood drew this difference between, like, we're both a harm reduction lowercase toolkit intervention, but we really embody the spirit of the harm reduction movement, which is that we're drug user led, we're drug user organized, and we really don't push recovery on the hotline at all. We are a safety line. We don't, this is very much caller driven. The caller drives the conversation. And I think it's really important because people if you think about our statistics, right, we've had 4,500 calls, 28 overdoses. 99.95% of our calls end uneventfully. So what happens on those calls? Beautiful things happen. People are talking, they're connecting, they don't feel isolated. They are, engaging in a way that maybe they're not accustomed to. You're talking to someone you've never met, you're having this really deep conversation about your life, and they're not pushing you towards treatment, and they're not making you feel like you're a bad person. And so I think it's really a model for that. And then the final thing that I'll just share with you is that I had the experience of responding to a Never Use Alone hotline overdose myself as a paramedic. And that was a really crazy experience. There's a video online you can find where I talked with a young woman who had overdosed. But I got to be out of the stream and in the stream at the same time, and that was really cool. So I think that's it. Thanks.
Our final panelist is Senator Josh Miller, who represents the District 28, which includes portions of Cranston and Providence and the Rhode Island Senate. Senator Miller was a driving force behind the enactment of legislation providing parity and coverage of mental health and substance use disorders. And he has championed a package of legislation addressing the mental health system aimed at improving preventative services and treatment, as well as a package of legislation addressing the opioid overdose crisis.
So how do I get this to, okay, I want to start with that one, because that's part of what she described with being a legislator. And I want to kind of fit this into the context of where we started, what good came out of COVID. Because what I'm going to talk about, if we can navigate to there, is the good things that came out of COVID. So one of the good things that came out of COVID was legislation that we really only imagined might pass, but actually did pass this year. And this signing ceremony, this is a porch at the State House that this is taken off of. That was a signing ceremony for 4 bills that passed in June, but the ceremony was a week or 2 ago. And you can see 2 of our friends, a rep and 2 of our friends from Project Weber Renew, who were so instrumental in much of this legislation. And I asked Kaylee to stay because she was part of all this, but she snuck out. And a lot of people in this room were really part of all this. So one bill that passed and was part of the signing ceremony was Senate Bill number 4, which was telemedicine. And we imagined this might pass, but we didn't imagine that it would become so significant in the context of COVID. And then we were worried that it wouldn't pass because it was Senate Bill number 4. And I say that because as chair of the Senate Health and Human Services Committee, I get to plan what we hear when. And we heard that bill in January along with the harm reduction legislation and the buprenorphine decrim, which were also part of this ceremony. And they were one of the first hearings we had because of the COVID component of them, right? That we had to indefinitely continue telemedicine. That because of the syndemic, as many of people have been discussing, we needed to pass harm reduction and we needed to pass decriminalizing buprenorphine. And a lot of these bills had been out there for years and didn't pass except because of the pandemic. And rather than the community of people like this group that works on these issues all the time, because of the pandemic and the context in which these things were discussed, they got understood by a wider group of people. So these things that felt virtually impossible became possible. So another thing that happened to me during the pandemic and that I worked at during the pandemic was I became chair of a group called the Downtown Improvement District. And there are downtown improvement districts and districts like them across the country that do mostly what we call clean and safe, which is beautification, litter control, and security. There's a security component to it. And so this guy in the yellow jacket, we call him the yellow jacket. I took this picture one day. I actually went around the block to get this picture because it demonstrates a couple of things. One actual and one discussed around the pandemic is their ability to be in the right place at the right time and help this woman who was stuck on a corner and couldn't figure out how to get across the street. You know, looks at least, you know, octogenarian and minimal. And you'll see on the bench there, Kennedy Plaza, this picture was taken, as many of you might recognize. And many of these people are homeless or SUD or seriously mentally ill. And what we were able to accomplish, as I put it into kind of hyperdrive when I became chair of this group in July, was we finally got the bathrooms open. During the pandemic, the bathrooms were closed. And as somebody who has learned over the last decade or so how to scream and yell a lot, I literally had to scream and yell almost at least once a week, if not several times a week, in order to discuss with people who should have known better that there was a health component to having a public bathroom when all public access to bathrooms was virtually closed. And it took a year, but we got it done. The other thing we got done literally last week was we reprioritized based on return to work. Sometimes you have to add some language in these things to get them done. Return to work, return to venue, homeless, the presence of homeless people in SUD and seriously mentally ill dramatically increased in this downtown footprint, which is only a few blocks from here. It dramatically increased. So we finally, after almost the same pattern of advocacy for the bathrooms, we now have a collaboration with the Rhode Island Foundation, Crossroads Rhode Island, who hasn't had outreach for 3 years. You had to come to Crossroads. Now we have a collaboration with city ARPA funds, private stakeholders, the DID, and about a half a dozen others to fund outreach. That includes not only, and this will probably actually be in place before the end of this year, at the longest. More security, the outreach component that will not only include homeless, because that's a fraction, a large fraction, but not the only fraction of those sitting on that bench. Some of those have housing, but are in a mental health rut or a SUD rut rather than a housing rut. So they'll collaborate to get those services. So that's another virtually impossible before COVID, now possible because of COVID. Where's the last slide? There, no, there. Nope. There we go. Okay, so my third part-time job is that I own Trinity Brew House, which is also about 6 blocks away, and it's a brew pub. And the good that came out of COVID is we had a crisis of hiring. And I have done this since several years ago, but it became a crisis, and therefore it was more of a necessity rather than an option to focus on hiring for those who are in recovery. I took this picture about a week ago. We haven't been open every day, and partly because of these people and a few others, we're going to be open every day next week. And it's always been a struggle, but also some of the most rewarding things you can do as a boss is focus on hiring those who are in recovery. And almost all of those, if many in the room might know Jonathan Goyer, who now runs the recovery workplace effort in Rhode Island. And so it's incredibly rewarding, but incredibly difficult to navigate these people. I'll be totally honest with you, but it's worth it. And I won't identify them directly, but one of these people, since we hired her, we hired her the day after she came out of inpatient. She went back to inpatient and came back out a week ago. And she's really talented at this point. The rest of them are relatively new and have relatively different experiences. But if I was to be a hackathon participant, and this goes to those people and the people you don't see in this photo, one of the things I would look at is treating the undocumented and having access for the undocumented, as well as we can have access to treatment and recovery for those who are not undocumented, because we literally had people during the same period that we tried to help and we tried to help ourselves because we wanted to fully reopen. That couldn't work for us because they couldn't access transportation. They couldn't only work day shifts if we wanted them to work, because RIPTA, our public transportation, virtually is not useful enough late at night for them to get home, and often to where their recovery housing is, where they're. And so one of the things, if I was hacking, two of the things would be to the culture of getting the same amount of services and the barriers for people who are undocumented, but also around transportation. I think it's time for something, and it works for a wide range, and we talked about it before COVID and there is some of this in place, but not as comprehensive as I would imagine, that would basically function for recovery and treatment services, and to get people from their housing a state-run Uber account. It would open up so much access to treatment and so much access to employment if we had a statewide Uber account. There are some of the services that are using this, but not to the level that would really make the radical difference. And that's one of the challenges I think that anybody looking in this realm should consider. That's what I got. And this is my version of PowerPoint. I knew I was going to be the only guy without PowerPoint. And then I said, can you PowerPoint 3 photos if I give them to you? And so this is my version. And I think they really show 3 very important access. You write a bill, it might actually get passed. With or without a pandemic. Take on some volunteer work that could have a radical impact where there's been virtually none because of the old guard that was doing it in the past. And sharp disposal is another effort that looks like it's coming to fruition downtown, based on Ocean State cooperation and Parks Department, and all these people who kind of sort of work together that are now forced to because of a crisis. Thanks.
Thank you so much to our panelists. I think we have time for just a couple questions. There's one that I believe was submitted virtually from Lori McDougall. And this one's for you, Dr. Whiteman, but if others can chime in, that'd be great. So Lori asked, I'm wondering if you saw the breakdown of barriers to access to BUPE in the Latinx and Black communities with initiating BUPE via telemedicine.
Is this okay?
Yeah.
I can talk, sorry. I don't do very well talking through a mask. With our hotline, we tried to increase access and lower barriers as much as we could. And I think one of the things I really learned through working on the hotline was just how much flexibility we need to learn how to build into not only substance use treatment, but healthcare. The number of patients that I had called that missed a clinic appointment and couldn't get a bridge script, and their providers, luckily we were available and sent them to us to provide that, or people who tried to access care and couldn't be seen for a week or two and were calling to get a bridge script to get them to that clinic appointment. We saw people whose clinics closed and didn't know where to go and didn't have access. And so we were able to connect them to treatment. And I think that flexibility that gets brought in of having a service that's available after hours so people can work and they can live their lives while being treated for a substance use disorder, and just lowering the barriers. So not everybody who calls the hotline has to want treatment. They could just want treatment for withdrawal that day and get a prescription to treat their withdrawal at that moment in time. I didn't exactly answer about communities. Apologies about that. With the hotline, just looking through our data of who we really served, I think we served about 40% of the people that called were non-white. We actually had a good number of people who are older call the hotline, which I thought was a really hard population to reach. And so I think it was a great resource. I don't know if it was having just a phone call available that really opened things up to that population. But I think the more that we can do to make services work for people in their lives and not have it be this thing that they have to adjust their lives completely in order to get to services and get to treatment, it's really, really important.
I might use moderator privileges as well and ask one question. And this one really is kind of for Gordon and Stephen. These are interesting innovations that involve a lot of buy-in from multiple folks. And I was just wondering if y'all could speak to kind of the processes, like Gordon, how did you build these relationships with supportive housing providers or the public washrooms where the sensors are placed? And similarly, Stephen, how have y'all built out this network across the United States of people willing to, donate their time?
You first? Well, I kind of insert myself into as many meetings as I can. I don't really say no to any invitations, and I think that's important because you never know, like, sometimes I'll go to a meeting of very like hardline abstinence recovery folks, and you don't go into that meeting thinking that a harm reduction safety line is going to be like an effective discussion to have. But it's amazing how many times I'll get like an email after from someone who didn't like say anything during the meeting, but they'll send me an email after like, hey, that really opened my eyes to harm reduction. And so like, I think that as we shift the American obsession over abstinence treatment to being something that's more reflective of like what recovery should look like or what recovery could look like, we need to push ourselves into those circles and say like, hey, this isn't actually the only way. And like, I'm a person myself who's in abstinence or based recovery for more than 10 years. And I'm telling you that it doesn't work. So because everybody I went to rehab with is dead. So I think it's important to acknowledge that like people like me are an anomaly to make it to this point. And so obviously the system that we have in place doesn't work. And so I guess to answer your question, like we need to challenge this. We need to challenge this belief, and we have to, as harm reductionists, because these are harm reduction services, like we have to be willing to go into maybe uncomfortable places to have these discussions with the police. I mean, I regularly have to have these discussions with police groups, trying to get them to hand out our cards, and a lot of them do. So we can find allies that we didn't think we had, and maybe make a difference.
I'll answer what I think the question was, or the way I'm sort of hearing it. the standard startup advice is to get out of the building. And that's because most folks who think of an innovation in the context of a hackathon or somewhere else we're sort of locked in a bit of a room. And so the advice is, get out of the building and validate your idea. In this context, what that means is to go and speak with people with lived and living experience of drug use. And then shut the fuck up and listen. Because your idea is probably a great little nub of an idea. And if you're lucky, it will stimulate something back to you. But even if it doesn't, if you just keep your mouth shut, eventually you're going to hear something that you never would have heard otherwise. And you take that and you build on that. And so that's how we've built all these relationships is by learning to keep our mouths shut. The original idea for Brave was, and forgive me for this, but I'm doing it on purpose, was Uber for Narcan. So you find somebody who's overdosed, you push a button, an alert goes out. People who have Narcan nearby or naloxone will get the alert and come and respond. The worst place in the world to try and build that in 2017 was downtown east side of Vancouver, because they didn't need that right then. Rural Indiana right now, that's still a viable thing, and that would still fly there. But what happened when I shut up was I learned that what people needed was a way to use it safely when they were alone. And so the Brave app came about. And then we spoke to people in housing and said, hey, this app, what do you think? People here. And then we spoke to the people in housing and said, hey, this app, what do you think? And they said, meh, not really. This thing is a tiny little button that we can stick up on your walls, and then people can just push the button, and then staff will know that room 203 wants you to go and check on them. How about that? And the context is you push the button once before you're going to use, and then multiple times if there's something emergency going on around you. How about that? Within 11 days of the first pilot, the first installation, there were 3 overdoses. So very rapid feedback that this was a thing that worked, meaning it made sense to the people that we were serving. And there was a lot of engagement that happened before that. And then people said, because we continue the conversations all the time, we're just talking and listening. They said, you know what, folks are overdosing in the bathrooms. We think that the buttons in the bathrooms would be a great idea. We said, okay, great. And so we stuck the buttons in the bathroom, and nobody touched the button. Nobody used them at all. And so then we listened to what some other folks were doing. So the Boston Medical Center had put these stillness monitors up in there, and we built a version of that. This is version 1, actually. We're on version 4 right now. But this gets stuck up on a ceiling. It's passively monitoring the space. You can unplug it and plug it in a new space and all that stuff. And it's going to send you an alert if somebody stops moving. And we thought that was really cool. And then they said, the way we actually try to keep our bathrooms safe anyway is by checking every 10 minutes. But we have 4 washrooms, 2 on this floor, 2 on the upstairs. So we're actually just constantly doing bathroom checks, and we're never actually complying with our own guidance, which is to be checking every 10 minutes. If this could just tell us, not just when people were still, but when somebody had been in there for 10 minutes, then that would be pretty cool too. So it's got a timer thing as well. So yeah, I'll shut up now.
No, that's great. So I think kind of key takeaways is listen, be nimble, and get out and talk to the folks, make sure that there's meaningful inclusion of people with lived and living experience. Cool. Thank you and happy hacking.